السلام عليكم ورحمة الله. In the coming maybe 5 minutes, I will talk about this work. We did it with our colleagues from different parts of the world. It's a clinical score to identify high-risk patients for monogenic lupus. Here is the co-authors from Saudi Arabia, Algeria, United Arab Emirates, Iran, Italy, and Canada, US, and Taiwan, and Lebanon. So the background for this work, as you know, monogenic lupus results from specific single gene variant causing inflammation and loss of tolerance. This is one of the pathways. Currently, the prevalence of monogenic lupus hasn't been systematically evaluated in large cohort. Typically, patients with monogenic lupus experience severe early onset disease. I will not go in details because we will discuss the items in a minute. The clinical manifestation of monogenic lupus vary based on genetic variant involved. And these features are non-specific to monogenic lupus, potentially leading misdiagnosed and delayed management, and this is what we are seeing in our practice. So we know that genetic testing, maybe it's not available in many centers, and also it's costly. So the idea of this study, or the objective, to develop an easy to use and time-efficient clinical score to identify monogenic lupus based on clinical presentation, and hopefully it will help to identify who may benefit from confirmatory genetic testing and promote prompt precise therapeutic intervention. So to summarize the methods, to create and validate the tool, we took the following step. 1, to create an item list, establish an expert consensus panel, reduce the tool to 10 items, just to be more practical, and calculate the cutoff value and evaluate the diagnostic performance of this score. So the steering committee created a list of all clinical and laboratory features reported in patients with monogenic lupus or lupus-like through a comprehensive English literature review. The data set derived from 33 carefully selected articles, including 55 items, and we categorize it in 12 clinical and laboratory domains. And here's the domains. We categorize it: demographic, constitutional, mucocutaneous, MSK, renal, neurological, cardiac, pulmonary, gastro, ocular, hematological, autoimmune, and immunological. So to establish the expert panel, we identified 16 pediatric rheumatologists with enough experience based on their publication and clinical experience, and 12 of them agreed and verbally consented to participate in this tool design. The panelists utilized in 2-round process, achieving we need at least 80% agreement among of those panelists to select the top 10 items. In the first round, each panelist independently assessed the clinical significance and relevance of each item, considering both the clinical and laboratory aspects. We tried to rating each item based on their relevance, clinical and laboratory significant, on scale of 1 to 4, rare, sometimes, often, and always. And we just retained those with rated 3 or 4. So this led to reduction of the items to 30 items. In the second round, we asked the panelists to choose the top 10, again, based on their experience. And this is the list we ended with. I will not read it, but this is the top 10 we thought this is relevant based on the expert panel. So the second step, to calculate the cutoff value and evaluated the reliability of this tool. So a pilot evaluation was conducted to assess the validity of the proposed clinical score. We're scoring 10 patients with monogenic lupus with confirmed pathogenic genes. And also we chose 30 control subjects, those 10 patients with systemic autoinflammatory disease confirmed by genetic testing. None of them had interferonopathies pathway. And 10 patients with JDM and 10 patients with sporadic SLE based on the SLEC criteria. So all patient data recruited from our pediatric rheumatology clinic at KFSH Riyadh. I will not go in details about the statistical consideration, but the most important to calculate the cutoff value of this tool. Of course, this study approved by our ethics committee at KFSH. So the result, the clinical score in this pilot consisted of 10 items as we choose or decide. And the items were scored at present, taking 1 or with weight 1. Absent means 0, so the maximum score will be 10. And the monogenic lupus, as I said, all of them, they have confirmatory genetic, and most of them, they have C1q deficient. And systemic autoinflammatory disease, as you can see, 3 had FMF, 3 MKD, and 1 with CABS, Majeed syndrome, and TRABS, and blue insufficiency. Monogenic lupus patient had a median age of disease 1.4, which is expected, and the control, they had the median age of 5 years. So monogenic lupus had markedly higher frequency in all items except systemic autoinflammatory disease. They had early onset as expected. This table just showed the prevalence of proposed clinical score, and you can see the monogenic lupus had higher frequency of all items except the systemic autoinflammatory. They had early onset comparing to other group. And the second table showed the score obtained in monogenic lupus. The mean was higher comparing to others, as you can see, 6.6. So there was statistically significant difference between the scores of monogenic lupus and controls. So we tried to come up with a cutoff value, and the cutoff value was 3.5, and we thought this is significant to consider it as the value to differentiate between monogenic and controls. So because early disease onset, as you can see in systemic autoinflammatory and even JDM, ANA positivity was frequent in all group, and the consanguinity as expected in our society. This maybe it's not enough to differentiate between the monogenic and the controls. So based on that, we thought presence of additional 3 items more than what I have mentioned is needed to certify monogenic lupus than comparing to the controls. So conclusion, monogenic lupus is probably a construct that includes a variety of clinical and laboratory features. Confirmatory genetic testing is critical to diagnosis, to make the diagnosis. Our study presented an easy, time-efficient score for clinically identified probable cases of monogenic lupus, particularly in situations with inconclusive genetic findings or limited access to genetic testing. This score for sure needs validation in diverse multi-ethnic population and correlation with genotype from a large cohort of monogenic lupus to establish its use. We have a limitation as expected. Yes, in previous work, we proved that AULR ACR criteria may help to differentiate, to make a diagnosis of monogenic lupus, but still there is no true gold standard classification criteria for monogenic lupus. We have an issue because all the patients were from Arab ethnicity and from single institution, so we need to replicate this result in other ethnicity. The other point, we had most of the patients had C1q deficiency. Again, this is not representative of all monogenic lupus. With that, I will stop and thank you for your listening.
Thank you very much, Prof. Al-Mayouf. We have time for one question, please. Dr. Sumbul.
Sulaiman, what would be your recommendation for the genetic testing in these patients? Would we test them for monogenic lupus, or you could even include those who get sporadic?
طبعاً, and this is one problem. We don't screen the systemic sporadic cases, so we don't know if they had genetic defect in the sporadic cases. But again, this tool to stratify patients who may need the genetic testing. In our practice, for sure, nowadays, because the facility is available, we screened all patients.
Thank you very much.